In rolling out our interventions, we look at four main components. The first one is CLTS, under demand creation, behavior change communication, WASH governance, and supply chain. So as we implement the approach, we look at villages on a case-to-case basis. There are villages where sanitation coverage is slightly higher and villages where sanitation coverage is low. So in areas where we have enhanced access, then we use behavior change communication to bring the village to speed in terms of attaining ODF. In areas where coverage is low, then CLTS becomes the most appropriate approach to ensure that access is attained at the end of the day. However, in many cases, we are able to combine the two approaches for optimal results. In behavior change communication, we have developed a number of materials to be used, and one of them is a poster. We also have brochures on hand washing and a brochure on surface latrine promotion. There are also flip charts, and we also have stickers. So these materials are used in different fora. For example, when we do the door-to-door BCC campaign, the primary material that we use is the brochure, and this brochure is used to facilitate conversation between the promoter and the household on one, proper hand washing steps, and two, the need to do so. If the household then doesn't have a hand washing facility, then they're encouraged to make one and use it at the end of the day. That comes as an action point after the end of this conversation. So the materials are effective because they are used as reference points by these households, because after the discussion is over, then they are put at strategic locations where each and every household member can access and make reference to it. Community-based promoters are basically resource persons identified at village level, and we identify community-based promoters with support from chiefs, assistant chiefs, and the public health officers. And because they are spread all over the program area and they live within the community, then it becomes very easy for them to reach out to the program beneficiary on a daily basis.
Watu wangu kwa sasa, wale walikuwa wakiumia mbeleni pengine kama mambo ya typhoid, magonjwa kidogo kama ya kuhara nini, kwa sasa area yangu hakuna. Nafikiri kama hiyo ukitembea sasa, hakuna boma utapata bila kuwa na choo, bila kuwa na hand washing, na hiyo kutumia jifu. Na pia machoo zote ziko safi kabisa.
Door-to-door campaign is one of the very effective ways of conducting BCC because one, it enables conversation between the health promoter, hygiene promoter, and the household. And in that situation, they're able to converse openly on sanitation concerns within the specific households and even take action points on things that need to be corrected. The beneficiary of this intervention is able to ask specific questions, and they're able to get instant answers from the health promoter, and therefore we find it more effective because, again, it ensures that everyone, just from the name door to door, it ensures that everyone is reached and no one then is left behind. So in that kind of approach, we also find it then easy to even reach people with special need and have a tailor-made conversation that will help them access sanitation facilities with ease, and also address their specific needs at the end of the day.